এই ক্লাসটা মোটামুটি দিস ইজ ফার্মাকোলজি ক্লাস, অ্যান্টিভাইরাল, antifungal, antiparasitic drugs. So this is a table taken from your pharma book only. What are the non-HIV or other than retroviral drug. So কি common viral infection আমরা face করি? একটা হচ্ছে herpes group of drugs, একটা influenza, আর hepatitis B and hepatitis C. Hepatitis B and C is very important for your exam also. Hepatitis B and C. সুতরাং hepatitis B and C কারণ এখন hepatitis C আগে ট্রিটমেন্ট বলা ছিল it is not curable, একটা sustained viral response. এই টার্মটা anybody have heard about sustained viral response? And coming later to that sustained viral response, let's start with the anti-herpetic drug. What are the anti-herpetic drugs? Commonly used are Acyclovir. এতগুলো ড্রাগের নাম দেওয়া আছে, হাইড্রোক্সিরিডিন, ট্রাইফ্লুরিডিন, Acyclovir. তার মধ্যে two more common drug are Acyclovir, Ganciclovir, Ganciclovir. These are the commonly used drugs for herpetic infection. So in herpes 1 and 2, we usually use Acyclovir. Anti-influenza drug. Now what is the drug of choice for influenza? Presently drug of choice for influenza is oseltamivir. So oseltamivir can act even amantadine resistant. So this is the second drug. So these are the two common drugs, zanamivir or oseltamivir, both can be used. Oseltamivir, zanamivir, mechanism of actions are same. In some country, zanamivir is used. In some country, oseltamivir. In India, oseltamivir is the drug of choice for influenza. For hepatitis B, now what is the commonest drug that is being used for treatment of hepatitis B? Previously, it was PEG interferon. PEG interferon is not the drug of choice now. Now, Tenofovir is commonly used, or Entecavir. These are the two common drugs now being used for the treatment of hepatitis B. Now hepatitis C, what is the drug of choice? Usually these are directly acting agent, that is DAA, directly acting agent. The most commonly used are Sofosbuvir and Daclatasvir. These are the two drugs used simultaneously for treatment of hepatitis C and showing a good response. Now anti-herpes drugs. So what are the herpes commonly encountered? One is herpes simplex virus 1, herpes simplex virus 2, varicella zoster virus, Epstein-Barr virus and cytomegalovirus. These are the common viral infection, herpes virus infection that we treat. Next, commonest drug, Acyclovir. This is deoxyguanosine analog, inhibits DNA. Most of the antiviral act by inhibiting DNA synthesis and further viral replication. So mechanism of action is DNA synthesis inhibit and replication is stopped. So virus specific enzyme for conversion to active metabolite, that is being inhibited. So what it inhibits? It inhibits herpes virus DNA polymerase. Herpes virus DNA polymerase is inhibited. So single line mechanism of action. Now what is the dose? Acyclovir used in chickenpox, that is varicella zoster. What is the dose in adult? 800 milligram 5 times daily for at least 5 days, and chickenpox treatment should be started on the very first day. If it is started late, it will be of no use. Same for other viral infection, herpes. Herpes 1, what it causes? May cause the herpes encephalitis and other sexually transmitted infection causes by herpes 2. Next is cytomegalovirus, Ganciclovir. It is an analog of Acyclovir. Most effective against the cytomegalovirus, also activated intracellularly by virus-specific thymidine kinase. It also inhibits DNA polymerase, viral DNA polymerase, Ganciclovir. This is the drug for cytomegalovirus. Now, influenza. Influenza, when to treat, when not to treat. There are clinical classification, how it is classified influenza. Can anybody tell how the influenza severity is classified? Although the last year a question from antigenic shift and antigenic drift has come, influenza should be clinically classified according to the severity by A, B and C. Anybody any idea about this classification? This is a WHO classification of clinical severity. Mild cough, fever, patient does not have any comorbidity. That means A. Mild symptoms only. There may be cough, there may be fever, headache or diarrhea, anything. This is a simple mild symptom without any comorbidity. This is A. B is mild symptom plus comorbidity. Patient either having diabetes, either having renal failure or patient having some liver disease. This is B, classification B. And classification C is maybe shortness of breath may be there, shortness of breath, respiratory distress, plus minus comorbidities. This is C. So when we should treat? Whether we should give antiviral to the A category of patient, so it can, antiviral is usually given only to category B and category C. So category B and C are the type of patient where we should start the antiviral. Now the drug of choice is oseltamivir. All patients in category B and C should be treated, receive oseltamivir. When it should be started? It should be started without lab diagnosis if clinical suspicion of influenza is there, because in all over India we don't have a biofire or PCR to diagnose influenza. So clinical diagnosis and the oseltamivir should be started within 48 hours. If it needs to be effective 48 hours, within the appearance of symptom of 48 hours, oseltamivir to be started and it should be continued for 5 days. What is the mechanism of action of oseltamivir? It is, there are two hemagglutinin and neuraminidase are the two peplomeres in influenza. It inhibits neuraminidase. Neuraminidase inhibitor, so oseltamivir is neuraminidase inhibitor. Most commonly used drug, it is a sialic acid residue. And it can also cover the amantadine sensitive as well as amantadine resistant patient. It is effective against H1N1, H5N1 and influenza B. They inhibit influenza virus neuraminidase enzyme. So influenza is covered. Two drugs you should know. One is amantadine or oseltamivir or janamivir. The mechanism of action is same. Now, antiretroviral therapy. Before we go to the treatment of HIV, you should know or recapitulate some point about the life cycle of HIV. Otherwise, it is very difficult to understand the drugs. So, how the HIV virus, this could be the CD4 cell. So there are two receptors, GP41, GP120. This is the HIV virus. So what are the co-receptors? What are the co-receptors? Co-receptors are CCR5 or CXCR4. These are the co-receptors. Then virus gets entry. On entry, main is reverse transcriptase. HIV is what type of virus? It is a RNA virus. By reverse transcriptase of the virus, it converted to DNA, then double-stranded DNA, and they enter the nucleus. So they integrate with the nucleus. So there is an enzyme integrase, and they form the host nucleus, proviral DNA. Then by transcription occurs here. They produce RNA and other protein for HIV. Then assemble and release. Maturity, mature HIV virus, and then again release to infect other cells. So these are the basic steps for HIV infection pathogenesis. The drugs are there for different steps. So what are the steps? Nucleoside reverse transcriptase. Mostly the one drug should be reverse transcriptase inhibitor, maybe nucleoside or nucleotide or non-nucleoside reverse transcriptase inhibitor. So what are nucleoside reverse transcriptase inhibitors? They are girobudin, didanosine, stabudin, lamivudin, abacavir, and amitriptyline. So, and tenofovir. Non-nucleosides are nevirapine, efavirenz, bilaviridin, itavirin. And protease inhibitor are ritonavir, atazanavir, indinavir, nelfinavir, sacuinavir. Our CCR5 inhibitor, this is the co-receptor inhibitor, is maraviroc. And entry inhibitor, enfuvirtide. This is T20, this is the entry of HIV is inhibited. And integrase inhibitor, raltegravir, dolutegravir. So these are the part where it acts. CCR5 co-receptor inhibitor, there are CCR5 co-receptor inhibitor, maraviroc. And then it is entry inhibitor is enfuvirtide, then it is reverse transcriptase inhibitor. Reverse transcriptase inhibitor are both nucleoside, non-nucleoside and nucleotide. Reverse transcriptase inhibitor and protease inhibitor, which forms this transcription part. So protease inhibitor acts here. So further maturity is inhibited by protease inhibitor. Integrase inhibitor, where it integrates, when this DNA integrate with the nucleus of the host cell, the integrase inhibitor are raltegravir and dolutegravir. Now when you should start treatment, what are the mechanism of action of NRTI? They inhibit viral reverse transcriptase. So the RNA cannot be converted to DNA. When you should start? What is the present guideline of starting CD4? Any HIV positive patient without considering the CD4 count. In all patients, the antiretroviral therapy should be started. What it is called now? HAART, highly active. This term should be remembered, highly active antiretroviral therapy. HAART should be started irrespective of the CD4 count. In all patients, this antiretroviral therapy should be started. Highly active antiretroviral therapy, use of combination of at least 3 drugs. At least 3 antiretroviral drugs to suppress the HIV maximally and stop the progression of the disease. Monotherapy with single drug is contraindicated. So single drug cannot be used for the treatment of HIV. Now what are the common combination? NACO recommended regime, TLD, tenofovir, lamivudin plus dolutegravir is the first choice regime. CD4 count, how will you monitor? What are the methods of monitoring of the treatment? monitoring of HIV or hepatitis B, all the first point is quantitative RNA PCR and the CD4 count, because depending on the CD4 count, opportunistic infection do appear. So CD4 count, and how the CD4 count is tested, what is the method? I have told during, so flow cytometry or fluorescent activated cell slaughter. So these are the method of monitoring. One is the quantitative PCR and another is flow cytometry. Flow cytometry is the method to detect the CD4 cell count. Opportunistic infection. There are primary prophylaxis and secondary prophylaxis. Common prophylaxis given against pneumocystis pneumonia, cryptococcal meningitis, and isoniazid preventive therapy for tuberculosis. So these are the common prophylaxis given. These are antiretroviral drug, already we have covered. I'm not going to this slide again. So these are the other regime. TLE regime, ALE regime, TL plus LR, that is Tenofovir, Lamivudine, Efavirenz, Abacavir, Lamivudine, Efavirenz, Zidovudine, Lamivudine. These are few regimes for HIV. Now what should be monitored? The toxicity and adverse effect should be monitored, high cost of the regime. That is why what is government has made ART center mandatory for all medical colleges, irrespective of whether it is a government medical college or private medical college. ART center is there in all medical college to supply these antiretroviral drugs free. So these are one of the conditions NMC criteria to open an ART center in every medical college. Now IRIS. IRIS I have told during HIV opportunistic infection. What is IRIS? Inflammatory immune reconstitution inflammatory syndrome. When it occurs, if there is patient having a very low CD4 count and a latent or an opportunistic infection, if you don't treat the opportunistic infection early, then IRIS, because there is a rapid rise of CD4 count with heart, and that may lead to inflammatory response. That is IRIS. Now hepatitis B. When you should treat hepatitis B patient? Hepatitis B, how will you diagnose? And when you should, which patient? Whether acute hepatitis B is treated? Acute hepatitis B is not treated. The treatment is for chronic active hepatitis. Chronic active hepatitis patients are usually treated with antiviral. Acute hepatitis B is treated with self-limiting supportive treatment. So acute hepatitis B virus is not treated with antiviral. How will you assess HBsAg positive patient for activity? How will you assess? Can anybody hepatitis B? What are the, how will you diagnose the hepatitis B is still multiplying or activity is there? One, you should count the hepatitis B virus quantitative DNA. Second is the liver function test. What is commonly done is ALT, alanine transferase, or that is also called SGPT. This level should be high. That is means their liver injury is going on. And other three, other point, any antigen we test for hepatitis B. Hepatitis B E antigen. This is a marker for multiplication. Hepatitis B antigen is a marker for active multiplication of hepatitis B virus. So these are the four markers: serological marker, measurement of hepatitis B DNA quantitatively by liver enzyme, non-invasive tests like SGOT, SGPT and SGOT to platelet ratio, transient elastography, fibroscan. Fibroscan is now a very common investigation to measure the elasticity of the liver tissue, though not specific. Liver biopsy if available. So, what is chronic hepatitis B? When HBsAg remains positive after 6 months of initial diagnosis. Hepatitis B is still positive after 6 months and the liver enzyme. Now, whom to treat? This is the guideline whom the patient should be treated with antiviral. Any patient having cirrhosis, all adults, children with chronic hepatitis B and evidence of compensated or decompensated cirrhosis should be treated, regardless of liver enzyme, regardless of hepatitis B antigen, hepatitis B virus DNA. So, even if those are below the limit in a patient having cirrhosis due to hepatitis B, you should treat with antiviral. Second part is chronic hepatitis B who do not have evidence of cirrhosis but are more than 30 years old and persistently abnormal ALT, that means SGPT levels is high and high level of hepatitis B virus replication, hepatitis B virus DNA more than 20,000 international unit. So these are the 2 points. One marker is international unit per ml that can also be reported as copies and international unit per ml regardless of hepatitis B antigen status. What is the normal level of ALT, SGOT, SGPT? Normal level কত থাকে? Usually between 4 to 36 or below 50. It should be raised at least 4 times. 50 to 60 hole, that is not raised. So you should have a higher ALT and levels. Whom not to treat? Not recommended or deferred without cirrhosis, persistently normal ALT levels and low levels of hepatitis B. Now, which low level? Can anybody mention? Less than 2000 international unit per ml is called low level. Less than 2000 and more than 20,000 is high level. So, and age less than 30 with normal ALT, but hepatitis B virus DNA facility is not available. Now, how the quantitative PCR is done? What type of PCR machine is required? Can anybody tell? There are real-time PCR. They are real-time PCR for quantitative evaluation of B, C or HIV or COVID. We need a real-time PCR. Now, recommended drug. One drug is Tenofovir, disoproxil fumarate, 300 mg once daily. This is oral tablet. Or Entecavir, adult with compensated liver disease and lamivudine 0.5 mg once daily. Adult with decompensated liver disease with 1 mg. So dose is changed in Entecavir. When it is with compensated liver disease, it is 0.5 mg and decompensated is 1 mg. And Tenofovir alafenamide fumarate. Once daily, that is 20. So 2 types of Tenofovir are available. One is disproxil fumarate. This is commonly used, 300 mg once daily, and Tenofovir alafenamide fumarate in 25 mg once daily. Tenofovir is acyclic nucleotide diester adenosine monophosphate. So once activated, it acts as a polymerase chain inhibitor. So it inhibits the DNA polymerase. All persons with cirrhosis with APRI score more than 2 require lifelong treatment. What is APRI score? I have mentioned previous slide. What is APRI score? That is the AST platelet ratio. AST platelet ratio HCV, hepatitis C virus. Now, which genotype is common in Indian context? HCV, you should also know the genotypes. Genotypes may be asked. In European country, the genotype 1 is most common. In India, genotype 3 is most common, and genotype 3 is more drug resistant and difficult to treat. Now, highly effective directly acting agents has changed the HCV treatment, and we are thinking of elimination of HCV by 2030. This is National Hepatitis Control Program guidelines, National Hepatitis Control Program. Now, whom to treat? Any individual diagnosed to have infection with hepatitis C needs treatment. The duration of treatment will depend on whether patient is having cirrhosis, patient is non-cirrhotic, whether there is any decompensation like ascites, varicose bleeding, or hepatic encephalopathy. This is a detail. What is sustained viral response? SVR I have mentioned. This is SVR. HCV RNA level remains low even after stopping of treatment to 12 weeks to 24 weeks. That is sustained viral response. HCV RNA remains low. HCV RNA not detected below the detective limit. Treatment completed. This is called sustained viral response. That means even after the completion of treatment, after 12 weeks, we test for HCV RNA, it remains in a undetectable or below the detection limit. That is called sustained viral response. Even there is this term, even if the cure is not there, we are using this term, sustained viral response. What are the regimens commonly used? Sofosbuvir and Daclatasvir. These are for 84 days or 12 weeks. So treatment duration is 12 weeks. Type 2, patient with cirrhosis and compensated cirrhosis, Sofosbuvir or Ganciclovir for 84 days. Cirrhosis which is decompensated, Sofosbuvir and Ganciclovir and ribavirin for 84 days. If ribavirin is intolerant, Sofosbuvir and Ganciclovir. Dose as well adjustment in PL-HIV, renal insufficiency in model treatment center. So at least you should remember one thing. If you don't remember all the regime, the common regime what is commonly used, Sofosbuvir 400 mg and Daclatasvir 60 mg for 84 days. At least you remember these two drugs, and they are directly acting agent and they can lead to sustained viral response or cure. So this is HCV. How they act? They basically inhibit RNA-dependent RNA polymerase. HCV and non-structural protein 5B RNA-dependent RNA polymerase. It is a prodrug converted to active form by intracellular metabolism. How it works? It inhibits the RNA polymerase and stops the viral replication. So already covered. At least remember these two drugs if treatment is asked. Now for parasitic, let's start with the amoebic dysentery or amoebic liver abscess. You all know what is the treatment. Metronidazole 800 mg or 400 to 800 mg TDS for 7 to 10 days. In severe case or in amoebic liver abscess, IV can be given. What are the luminal amoebicide? Sometimes along with the metronidazole, diloxanide furet. This can be used as luminal amoebicide. These are used previously, quinidochlor, idoquinone. So for acute amoebic dysentery, remember metronidazole only. Metronidazole can be sufficient for amoebic liver abscess. Either you can give oral or IV for 6 hourly, or tinidazole 2 gram oral for 3 to 6 days, or 800 milligram IV for 6 days. And luminal aminoside sometimes used along with this, chloroquine and dihydrohepatine. So again, for anemic liver ulcers, either metronidazole or tinidazole is the drug of choice. Now, anti-helminthic drug. Helminth is another common cause of infections, basically intestinal, large intestine or small intestinal infection. What is the most common used drug is albendazole. Albendazole and mebendazole. What is the advantage of mebendazole? Mebendazole you have to give twice daily for 3 days. Albendazole you can give a single dose followed by another dose after 14 to 21 days. In some of the cases, you have to give albendazole continuously. What are the common conditions where you have to give albendazole? One is neurocystic sarcosis, where albendazole to be continued continuously for 1 month. Also, other for roundworm, hookworm, albendazole, mebendazole. For whipworm and trichinella, albendazole, mebendazole. For tapeworm, praziquintal, albendazole. Previously for neurocystitis, praziquintal was drug of choice. Now praziquintal is the second drug of choice after albendazole in neurocystic sarcosis also. Hydatids, again albendazole, mebendazole. For threadworm, again ivermectin or albendazole. For filariasis, diethyl carbamazine, ivermectin and albendazole. These are the 3 drugs. Choice of drug. The same roundworm, mebendazole or albendazole. Hookworm, pyrental pramoid, albendazole or mebendazole. Enterobius, these are same. For strongyloides, tuberculosis, ivermectin is the drug of choice followed by albendazole. Ivermectin or albendazole are the first drug of choice for strongyloides, and trichiuria again mebendazole or albendazole. Filaria, diethyl carbamazine is commonly used drug. Cutaneous larva migraines, ankylostoma caninum, albendazole or ivermectin. Can anybody tell which organism causes larva currents? Larva migraines is caused by some hookworm which are not human pathogenic, dog hookworm that can cause larva migraines, which causes larva currents. Strongyloides usually causes larva currents. So larva migraines and larva currents, if difference comes, larva currents is caused by strongyloides. Hydatid disease, Echinococcus granulosus. Mebendazole has produced nearly 100% cure in roundworm, hookworm, enterobius, but is less active on strongyloides. So strongyloides you have to give ivermectin as a first choice. The mechanism of action, microtubular protein beta tubulin of the parasite, it binds there and inhibits the polymerization that leads to intercellular microtubules are gradually lost. It blocks the glucose uptake and mitochondrial enzyme and depletes the glycogen store. This is mechanism of action. Mechanism of action will, this is one case, 40-year-old male, 60 kg, presented with 2 episodes of sudden onset fit. There is past history of patient has been headache for 1 month. His wife who witnessed the fits gave a description that fitted tonic-clonic type of seizure, some behavioral change. Fits are followed by confusion, behavior and drowsiness. So this is a case of neurocystic sarcosis. So what should be given for the question is, along with anti-helminthic, you should give steroid also, because there is perilesional edema that leads to increased intracranial tension and that leads to the seizures. So raised intracranial tension, and that should be if other medication needs to be given. Albendazole is the drug of choice. over praziquintal, the course of treatment is shorter, 8 to 15 days compared to 15 to 30 days. Cure rate is high, 75 to 80% with albendazole, praziquintal 50 to 6%, and corticosteroids should have to be given. That one part, it reduces the edema, perineal edema, and the corticosteroid also enhance the absorption of albendazole. So steroid should be given along with albendazole. And it should be started, this point you should know, the steroid should be started 2 days before and continue till 2 weeks after completing the anti-helminthic course. So because steroid should be started early, before 2 days, otherwise there may be convulsion on starting the anti-helminthic, and after it should be continued 2 weeks after also. So this part, hydatid disease. Hydatid disease, what is the treatment? Most common treatment is surgery. If it is feasible, the excision of seed without puncturing it, because hydatid fluid can cause anaphylactic shock. So if it is sometimes asked in the Viva also, if hydatid fluid is leaked during the OT, patient may have anaphylactic shock. So that's why it should be very careful for removing hydatid cyst. There was a news in today's newspaper or yesterday's newspaper about a hydatid cyst removal in some district hospital in Bardhaman, and they have removed it intact. And that location, what is the common site of hydatid cyst? Common site is liver, second is lung, but this patient had cyst in peritoneum. It was more difficult to remove. So another treatment who cannot, some contraindication to surgery, pair, puncture, aspiration, injection and re-aspiration. So this is another treatment method, pair, puncture, aspiration, injection and re-aspiration. And there may be some scolicidal agents like hypertonic saline, cetrimide or ethanol can be added. Pair claims higher cure rate. Pair is recommended for single hepatic cyst and uncomplicated. Now this surgery already I have mentioned. Antiparasitic agent is albendazole. Now filariasis, treatment in DEC, 2 mg per kg thrice daily for 21 days. Microfilaria disappear from blood in 7 days. The most important action appears to alternation of organelle membrane. So diethyl DEC is the drug of choice. Diethyl carbamazine is the drug of choice for treatment of filariasis. Sometimes 12 days or 21 days given. Other treatment of filariasis, albendazole is being now given for 21 days, ivermectin, other alternative choice. So these are the action of some anti-malarial drug. This is your pharma table. I am not going. Pharma, the treatment of malaria is very simple. For Vivax malaria it is different, and falciparum malaria it is different. For Vivax malaria, where the area is chloroquine sensitive area or there is no history of chloroquine resistance endemic area, you should give chloroquine and along with primaquine. And primaquine to be given after G6PD test, because without G6PD test, if G6PD is low, patient may have severe hemolysis. So that is the treatment. And for falciparum malaria, the treatment is artesunate with some drug. In all other states except the northeastern state, sulfadoxine pyrimethamine is given with artesunate for and along with a single dose or 3 days of primaquine for 45 days. This is for artesunate compound. One thing you should remember, artesunate cannot be used alone. Artesunate should never be used alone. That can lead to, there is no evidence of artesunate resistance in India. So it should not be used alone to prevent development of resistance. Now, what is the treatment in chloroquine-resistant vivax? What should you give? Chloroquine-resistant vivax malaria. Pharmacy the class hoye geche. What is the treatment in case of chloroquine-resistant vivax malaria? Chloroquine-resistant vivax malaria ki debe? Artesunate compound is usually used for chloroquine-resistant vivax malaria also. So, artesunate is used. Artesunate compound is used. For northeastern trace, artemether and lumefantrine is used. Now, visceral leishmaniasis, what is the drug of choice? Liposomal amphotericin B is the drug of choice. Previously, pentavalent antimonial was used. And miltefosine, what is the advantage? Why it is specially mentioned? Because this is an oral tablet, can be given from as prophylaxis or initial treatment in health center also. So, miltefosine you should remember, it is available in all the health center, is an oral tablet, or all others are IV drug. Liposomal amphotericin B is the drug of choice. So, drug of choice usually was pentavalent, now miltefosine 150 milligram per day orally for 28 days. So, this is the mechanism of action of miltefosine. Paromomycin, another drug, can be used in. This is the WHO recommendation. You can see liposomal amphotericin B has been the drug of choice for Indian subcontinent or liposomal amphotericin B plus miltefosine. So, viral visceral leishmaniasis, this is the treatment. In Africa, still pentavalent antimonial is the drug of choice. Why pentavalent liposomal amphotericin B? What is the side effect or what is the constraint for using liposomal amphotericin B? It is costly than other drugs. It is more costly than plain amphotericin B. Liposomal amphotericin B is more costly. Fungal infection. So, how will you control the fungal infection? Still no vaccine is available. So, first control by sanitary means. Many antifungals are available but sometimes very toxic. Topical powders and creams contain azoles and tolnaptates. Useful against superficial dermatophytes. Porotrichosis may be treated with potassium iodide or amphotericin B. Systemic infection are generally treated by amphotericin B, fluconazole, voriconazole, itraconazole. So, you should know which fungal treatment. One is dermatophyte. These are the antifungal drug tables. Amphotericin B, echinocandins and the topical. Echinocandins, what is the role? Caspifungin, micafungin, anidulafungin. Echinocandin আমরা কোথায় ইউজ করি? Echinocandin most of the candida now we are detecting are having azole resistance. So, fluconazole or ketoconazole, sometimes any patient admitted in ICU detecting a fungemia or candidemia now should be treated, whether it is a albicans candida or non-albicans candida, should be treated with echinocandin. So, these are the some mechanism of action. So, terbinafine inhibit the squalene epoxidase and azole inhibit lanosterol 14-demethylase. So, they prevent ergosterol formation. Ergosterol is a part of fungal cell wall. These two I am just mentioning, not mentioning other. Another is the beta-glucan, caspofungin inhibiting beta-glucan 1,3 beta-glucan synthase complex. So, they are inhibiting the beta-glucan synthase enzyme leading to prevention of beta glucan formation. So these three, if you want to know the mechanism of action, just three parts. One is this lanosterol demethylase inhibitor, preventing the formation of ergosterol, and beta glucan synthesis inhibitor for caspofungin. Echinocandin, because this is now the most common drug used in ICU for candidemia. Candidemia or systemic candida infection, echinocandins are commonly used. And even it is effective against aspergillus. Synthesis of beta-1,3-glucan. Griseofulvin. Griseofulvin किसे दिखा रहे हो? What was commonly used griseofulvin? For nail infection, nail fungal dermatophyte infection. Previously griseofulvin was used. Nowadays, what is used for nail infection? Dermatophyte infection. Now, what is the drug of choice? Now, for dermatophyte infection, either you can give fluconazole oral or itraconazole. What is the dose? Itraconazole, either 100 milligram BD or 200 milligram OD for 1 month, along with topical antifungal. So, itraconazole is commonly given for dermatophytic infection, and 3 dermatophytic species are trichophyton, epidermophyton, and microsporum. Azole, they inhibit fungal cytochrome P450 and lanosterol 14-demethylase. Thus, it inhibits the ergosterol synthesis. Posaconazole. What is the importance of posaconazole? COVID there was zygomycetes infection. Posaconazole is the only azole effective against zygomycetes. Posaconazole is the only antifungal that are the antifungal active, and they are effective in mucormycosis. This was being used when mucormycosis was a side effect of COVID. Flight fluorocytosis কোথায় ইউজ হয়? 5-FC for cryptococcal meningitis. Cryptococcal meningitis we usually use 5-fluorocytosin as no anti-cancer activity when it is low capacity. The fungal selectively depends on the fact and is a narrow spectrum fungistatic active against cryptococcal neoformans. So it is given in cryptococcal meningitis. So, successful treatment of mucormycosis, surgery is the treatment of choice, and along with amphotericin B and posaconazole can be given. So, these are the few for the medicine book. Immunocompetent patient, whether it is a disseminated pulmonary infection from histopulmosis or other dimorphic fungi, the treatment of choice is amphotericin B. Cutaneous mycosis. What are the 3 cutaneous mycosis or dermatophyte? Trichophyton, microsporum, epidermophyton. Exclusive tinea infection, terbinafine can be used, itraconazole can be used. Onychomycosis, terbinafine, itraconazole can be used as oral drug. Esophageal candidiasis, fluconazole tablet, if it is systemic involvement, caspofungin or micafungin. Pneumocystis girovisi, now treated as fungus. So, what is the treatment of choice in pneumocystis girovisi? It is cotrimoxazole. No antifungal agent. Trimethoprim cotrimoxazole is the used treatment for pneumocystis treatment and also the prophylaxis. Aspergillosis, what is the treatment of choice? You can use voriconazole as a primary treatment or amphotericin B, caspofungin, posaconazole. This is for invasive aspergillosis.